Hey friends, welcome back to Think Like a PMHNP. I'm Kiara, a board certified psychiatric mental health nurse practitioner, and on this series, I teach you how to think through psychiatric cases the way we do it in clinical practice. Whether you're a nursing student, a PMHNP student, new provider, or you're just interested in learning psychiatry a little bit better, you're in the right place. Today, we're talking about one of the biggest misconceptions in mental health. Hallucinations do not automatically equal schizophrenia. Let's think it through. The first question I ask when a patient tells me they're hearing voices or seeing things that other people don't see, my brain doesn't jump straight to schizophrenia. Instead, it starts building a differential diagnosis because hallucinations are a symptom. They are not a diagnosis. One symptom can occur in a dozen psychiatric, neurologic, or medical conditions, which is why it's so important to slow down before labeling somebody. Step one, my first goal is understanding exactly what the patient is experiencing. Are they auditory hallucinations, visual hallucinations, tactile hallucinations, olfactory hallucinations, hallucinations? Then I want details. What do the voices say? Are they inside or outside of your head? Do they command the patient to do things? Are they distressing? How often do they occur? Are they occurring while falling asleep or waking up? The more information I gather, the better my differential becomes. Step two, when did it start? Because timing matters. Did this develop over several years or did it begin yesterday? An acute onset makes me think differently than symptoms that have gradually progressed over months. Sudden hallucinations always raise concerns for possible medical causes, substance use, intoxication, withdrawal, delirium, or neurologic conditions. Step three. Now we want to start asking, are the hallucinations the only symptom? Or is there more going on? I'm looking for things like delusions, disorganized thought processes, a disorganized behavior, negative symptoms, cognitive decline, changes in occupational or social functioning. Remember, schizophrenia isn't diagnosed because someone hears voices. It's diagnosed because they meet specific diagnostic criteria over time. Step four, this is where clinical reasoning becomes so important. Hallucinations can occur in schizophrenia, schizoaffective disorder, bipolar disorder with psychotic features, major depressive disorder with psychotic features, PTSD, substance induced psychosis, delirium, dementia, Parkinson's, Lewy body dementia, temporal lobe epilepsy, brain tumors, sleep deprivation, medication side effects. That's a long list. So, why would we immediately assume schizophrenia? We shouldn't. Step five. One of the biggest mistakes new clinicians make is forgetting the medical workup. Depending on the presentation, I may consider substance use history, medication review, laboratory studies, urine analysis, urine drug screen, thyroid function, vitamin deficiencies, infectious causes, neural imaging when clinically indicated. Psychiatry doesn't happen in isolation. Medical conditions can absolutely present with psychiatric symptoms. Treatment depends on the cause. Treatment isn't hallucinations equals antipsychotic. Treatment depends on why the hallucinations are happening. If they're caused by schizophrenia, the treatment plan will look very different than if they're caused by bipolar disorder, delirium, substance use, or a neurological illness. That's why getting the diagnosis right is so important. Treating the symptom without understanding the underlying cause can delay appropriate care. PMHNP Pearl for you. One of the biggest shifts you'll make as a clinician is learning to stop asking what diagnosis fits this symptom and instead asking what diagnosis could explain this entire presentation. That small change completely transforms your clinical reasoning. Hallucinations are an important symptom, but they're only one piece of that puzzle. As PMHNPs, our job isn't to diagnose the loudest symptom. Our job is to recognize patterns, ask better questions, rule out other possibilities, and build the most accurate diagnosis we can. That's what I mean when I say think like a PMHNP. Remember, good clinicians don't just memorize diagnoses, they learn how to think them through. Thanks so much for watching. If you enjoyed this video, don't forget to like, subscribe, share it with someone learning psychiatry. I'll see y'all in the next one. Bye.